So, hi everyone, just to confirm, can you hear me?
Yes.
Okay, very well. So my name is Taehoo. I'm a pediatrician in radiology. I'll be giving you a little talk on how to read a CT abdomen, and there's no prelim report available. The objective here is really to identify what can kill the patient in CT abdomen, and hopefully that it will save the patient. Are you guys all emergency emergency residents, or there are like med students, or what are?
It's mostly emerge residents. There's a few staff, maybe one or two students as well, but mostly residents.
Okay, perfect. So just a little disclaimer, CT scans can be useful, but can be useless. So your clinical judgment never replaces CT abdomen. And I'll give you an example. If the patient is super unstable, then the patient is for little POCUS on the spot and straight for OR instead of waiting for CT. Another example would be if you're looking for gynecological etiologies or something in the scrotum in males, you have to ask for ultrasound, not CT scans. So you have to know when to choose it wisely. So I divided the section into 4. So mainly what can kill the patient: free air, free fluid, all the itis, meaning like inflammatory changes like pancreatitis, cholecystitis. I'll talk about them briefly. And then in the end, I'll talk about the lines. So NG2 is Foley catheter. So instead of waiting for results like SpongeBob here, you can jump into CT scans right away and check for these findings. So before we talk about what's abnormal, I wanted to show you what's normal and also my own search pattern when you only have 60 seconds. So reading a CT scan can be very easy. I like to start with a scout image. A scout is basically what CT techs use to know where to scan in the body. And it's like a blueprint for the CT techs. The reason I like to use it is because it's just like X-rays. So you have the scout of the CT abdomen here, and basically you have the same view as you read an X-ray. So our eyes are really used to it. What you can check on here is any pelvic fractures, any free fluid under free air under diaphragm, and you can look for bowel gas pattern. So once you're through that, I'll ask you to jump to the CT axial view. So here, what you're looking for, I don't expect you to go through organ by organ, but really to look for anything that jumps out, anything that stands out, any big inflammation, fluid collection, big fracture. Those are the things that you'll be looking for. Don't pay attention to the little cyst or the little small details. And then you can always go back and forth, like scroll up and down to go back to where you think abnormalities. This is a normal CT scan, by the way. So here, things you have to pay attention to is little spaces like here, the Merson's pouch, splenorenal spaces. And if you go further down, this is a female. So you can have fluid in the recess here or the pouch of Douglas. These are where you will have free fluid. Free air will be more in the antidependent area like here. Most of the time we see them anterior to the liver. So here this is normal, but you could have free air around here. And then what I do is I change to the lung sequence. So here you see the lungs, they're filled with air. So this is dark. And when you go down, you have to look for those air outside bowel lumens. So these are all contained there. So this is normal. If you had those dark areas outside bowels, like if you had this, but here, there will be a pneumoperitoneum, here too. And then I like to go to the bone window to look for fractures. Here I don't care about rib fractures or small spinal fractures. It's more the pelvic fracture that can kill the patient because it can cause a lot of bleeding. And then I look at the bone window on coronal. Why coronal? Because just like the scout image that I showed earlier, pelvic and femoral neck fractures are better seen on coronal view. And then, still on my bone window, I go to my sagittal. Sagittal is sideways, so here's the best to see for check for spine. So I scroll like up and down a bit more to check if there's anything big that pops up. And then I like to go back to my, still on sagittal, but on my abdomen window. Why? Because I talked about the pouch of Morrison in females, rectovesical space in males. That's where you can check for the free fluid easily, easier than axial. So that's my quick search pattern if you only have 60 seconds in emerge. Now that you saw the normal CT, let's talk about pneumoperitoneum. So there are different causes of pneumoperitoneum. Most often we think about bowel perforation. So let's take a look at a bowel perforation. So this is the case number 1. Ignore the pleural effusion here. I'll show you this. So it's just like getting your first impression. You have to see what pops up, what looks the most abnormal here. I know that everything looks a bit dirty, strandy, but if you're scrolling once and there's something that caught your eye, that's really good. So for this case, I'll just guide you. Everything else was fairly normal except for the small bowel. Here, I'll just pause it there. So if you saw this segment of small bowel and thought, oh, that looks very abnormal, then you're right. This is a case of trauma. The guy was riding on a motorbike and had a traumatic injury, came with abdominal pain. And this is very abnormal looking small bowel, which has lost its bowel signature. Small bowel should look like this. It should have normal enhancing wall. It should be thin, shouldn't be dilated, and it should be free fluid or air filled. No fecalization, no fat stranding next to it, no inflammatory changes, no free fluid around it. But here, it looks like a sausage. It looks very inflamed, edematous. I cannot differentiate between the thin enhancing wall and its content. It's very strandy around. And if you check again, I'm sure you've noticed there's a lot of free fluid around. All this gray stuff that's not contained, that's all free fluid. And you can track it down in the pelvis as well. And what's more abnormal here, the theme was pneumoperitoneum. So this is normal bowel, but that's free fluid. This is not as evident, but that's also free fluid. So what I can tell based on this, if I only had this finding, I could have said it's either infectious enteritis, inflammatory enteritis, or it could be ischemic. But because I have free fluid, free air, and the context of trauma, I can confidently call this a small bowel perforation. And there's a companion case. So if you had that finding earlier, plus you see this soft tissue, fat stranding and hematoma, and there's also fracture going through the 54321L1 vertebral body all the way to the posterior column. I don't know if anyone can tell me what this could represent, what kind of sign in the context of trauma. There's a name for it. There's small bowel injury. There's an anterior abdominal wall fat stranding and hematoma. And this is called chance fracture. There's a fracture involving the anterior and posterior columns of the vertebral body in the lumbar spine. All this grouped together there's a name for it. Can anyone speak up? No?
Do you mean seat belt?
Yeah, the seatbelt sign. Good job. So the reason I'm showing you this, good job, Miriam, is because if you had this when you were scrolling down the CT, you have to look for all the other signs because it's a good hint. Let's say on the bone window you found this fracture, you don't stop there. You have to look for this fast trending, you have to look for abnormal bowel injuries. Okay, so that's seatbelt sign. Now, this is another case. So you already see that this is a long window. It shows very well the free air under diaphragm. All this is free air. Now, instead of going down, I'm gonna go up. Can you deduce, oh sorry, it's going really fast. I'm gonna do it again. Can you deduce what could be the cause of pneumoperitoneum here? We are going into the lung. Here, the key is to find where the air is tracking. So the number one cause of pneumoperitoneum in non-trauma setting is duodenal ulcer perforation. Trauma can be any hollow viscous injury, but you also have to think outside the box. So here I'm showing you a pneumoperitoneum. Can you appreciate the air within the anterior mediastinum?
He has a pneumopericardium, so I'm wondering if he has airway injury or esophageal injury secondary to the
so he's intubated. Yeah, so there are many hypotheses, but here I'm not given the cause of it. Unfortunately, I don't know the cause, but I just wanted to let you know that you have to think of the airways, you have to think of the mediastinum as well when you have pneumoperitoneum. Also, a big pneumothorax can give pneumoperitoneum. Okay. Another case. So this, I'll give you the answer. These are all small bowel loops, dilated, and you have the thickened wall. You see that? And this is all the same patient. You see within the small bowel wall, there is a lucency. This is not outside the bowel loops, like I said earlier, but these are within the bowel loop wall. And there's also air in the liver. Does anyone know what this could be sign of?
ischemic bowel with compression.
Could you repeat that? Sorry, Mostafa?
Ischemic bowel with probable
Yes,
compression.
exactly. So this was a case of small bowel obstruction with bowel ischemia. So the bowel loops are dilated, and this was detected too late. So this patient developed pneumatosis intestinalis, all these air lucencies in the bowel walls, as well as portal venous gas. So all this air gas is tracking up to the liver and causing some air in the liver itself. The way to differentiate between a portal venous gas, which is a more urgent sign, compared to pneumobilia, which is air within the biliary tree, is that portal venous gas is more peripheral. It extends all the way to the margin of the liver, whereas pneumobilia, which is most often seen post ERCP, like stenting, which is like normal finding, it'd be more closer to the hilum around here. So good job. Now, here I'm gonna be showing you 3 slices of CT of the same patient who comes with abdominal pain. I need you to find what could be causing the patient's pain, okay? So this is the upper abdomen where it shows the liver, gallbladder containing something. It shows some part of the stomach, left kidney. So take a look at this. And then same patient, I'm scrolling a bit further down. Now I'm passing the gallbladder. There's still the kidney. This is the stomach, level of the pylorus, duodenal bulb, pancreas. So have a look at this. And then the last one, further down in the pelvis, now we have the sigmoid, some free fluid. Okay, so it's all the same patient. Do you think it's A that's causing the patient's pain, B, or C? Anyone?
Is it B?
Yes. Why do you think it's B?
You have fat stranding around the duodenum. You have a little bit thickening of the duodenum. You have free air, 3 spots around the duodenum, and you have an A, the free air also, a little bit of dots.
Yeah, awesome. Good job. If you were able to scroll this, then it would be easier to say this is actually a perforated peptic ulcer. Duodenum looks a bit enhancing dilated because it's reactive to the adjacent inflammatory changes. And here I don't have that cut, but if you were to scroll up and down, you could have appreciated that the stomach wall there's a discontinuity to it. And yeah, you're right, there's free air. See, it's very tiny, but you have to catch these, that they're outside the lumen. And there's a lot of fast stranding. A, this is just uncomplicated cholecystolysis. There's nothing wrong with it. And C, I wanted to show you uncomplicated diverticulosis. It's not a diverticulitis. And free fluid is likely from the reactive changes here. So good job again, Mustafa. So that was my brief review on pneumoperitoneum. Now I'm going to move on to free fluid. So free fluid, most of the time we think of blood. So if it's fresh blood, the Hounsfield unit will be 20 to 40. And if it's clotted, the density will be higher. So that means normal ascites, like no blood, it will be light gray on CT. Free blood will be a bit more denser, so darker. Or it could be a bit more enhancing if it's like there's extravasation, so it could be brighter than gray, which is the ascites. And if it were clotted old blood, then it can be variable. It can contain some acute bleeding, or it can contain like more darker blood, so darker gray. So before we talk about like huge pool of free fluid, I wanted to show you this first. So this is 2 images of the liver, and this is portal venous phase, and this is arterial phase. So in trauma, we always do multiphasic CT abdomen. And what I wanted to show you is, you see how well we can see the linear hypodensities in the liver parenchyma. Whereas on the arterial phase, yeah, you can see it, but if I didn't have this portal venous phase, I might have missed it. So this is a liver laceration in trauma, and this is called bear claw sign. This is like a burst type laceration where it's like a crush injury. You always have to look at all the phases. If you only saw the arterial phase, thinking, oh, I'll be able to catch active extravasation, then you might miss laceration like this on a portal venous phase. This will be AAST grade 3 at least, because it's more than 3 centimeter laceration. I don't see any other subcatheter hematoma or injury to the vessels here. But that's a liver laceration. So far, so good. Okay, this one. Also a trauma case. Can you see anything that's abnormal?
Spleen looks delicious.
I'll go back up. Yeah.
So it's arterial phase, but still, yeah, there are some ischemic part of the spleen, non-enhancing. But still, this is arterial phase. I would look at the portal venous phase. Also, there is some free fluid in the abdomen.
Yeah, so this case, you're absolutely right. This is a splenic injury. So this is a completely shattered spleen. So AST grade 5. Why?
Yeah.
Because you barely appreciate normal splenic tissue, and there's a lot of hematoma. And like Mustafa pointed out, you see this bright density. This is different than the free fluid here, you see? That's all hemoperitoneum, by the way, but this is too bright. So that's the contrast that's extravasating. So there's active bleeding, so you have to call surgery or IR for embolization in this case. So that's the extravasation is from the splenic fracture near the hilum. So good job again. So you can see there's a lot of pneumoperitoneum trekking down to the pelvis. This is all free fluid. This. I'm sure with this amount, you'll be able to see it easily on POCUS. I'll just check who's writing here. So the standard order in which the different image series are typically done. Oh, okay. Looking at the right series for the right pathology. So you mean like which sequence it is, I guess? That was your question, Monica? Yeah. So trauma case, usually it's done with arterial and portovenous phases. And I don't have my PACS open here, but on the left-hand side, left upper hand side, there should be a little label say it's arterial versus portovenous versus delayed. It's always labeled by text, so that should help you. Also, like you always look at the aorta. If the organs are not well enhanced like this one, but the vessel is, then that's the arterial phase and that's the portovenous. Like us, we are trained to look at everything. There's not a right order, but we suggest in trauma cases, you start with the arterial phase and portovenous side by side, and look if there is anything that's extravasating, like in this case. And if you have this, and if you're lucky, sometimes they do C- without contrast. So you go back to C- to see if there's anything bright in that area. If there is, then it's not contrast extravasating, it's just calcification or suture material or anything. But if you have this pooling of contrast, and if you have delayed, like which is taken 5 minutes or 10 minutes after the portovenous phase, and it's like getting bigger and bigger, it means the blood is pooling there. So it's another indication. But most of the time you just do classic, which is portovenous phase for any other type of abdominal pain. So focus on portovenous phase, and if you do find something, you can always go to other sequences to correlate. Hope that answered your question. Okay, number 8. Yeah, so it's a single image. Here, you need to be able to tell me, is it the free fluid is more on the right side or on the left side? Can someone type in the chat or tell me, right or left?
Right.
Right, very good. Can anyone tell me where this free fluid might be coming from?
Kidney.
Yes, right kidney. So here you cannot really say if it's blood or if it's free fluid unless you put a Hounsfield unit on it. But if I told you that this patient was known for renal colic in the past, now he walks into the emergency room because of right flank pain, then my first bet would be to think of Achilles rupture, not blood. In the trauma setting, yes, you will be thinking of hematoma or vessel injury, but if the clinical history was renal colic, then and there's free fluid around the kidney, I will be thinking of Achilles or Achilles rupture. I'll show you other images here. Same guy. You see, this is the bladder distended. Those are the UVJs. And you see this hyperdense thing, that's the stone. And it's obstructing, causing mild hydronephrosis, and there's free fluid. How do we confirm if it's blood or it's urine that's being leaking? You do a delayed phase. So that means this is C-. There's no contrast injected. And then when we do inject contrast and wait for 10 minutes for the contrast to be excreted by the kidneys, then you will have this. You see how beautiful the left kidney is. You see the contrast material in the collecting system in the proximal ureter. On the right side, see, it's all leaking to the perirenal spaces. So this is called urinoma, collection of urine with active contrast extravasation. So that's when you call urology. Any questions so far? Okay. Number 9. So already you can appreciate there is something here, right? This is outside of organs, and this is very dense, so it's with contrast. You see there is no contrast injected. You can check the aorta. We didn't inject anything through IV. So let's see where this contrast is coming from. I'll go back up. Can anyone tell me what you see here? This is a CT cystogram, meaning there's a Foley catheter here. And we injected contrast manually through the Foley catheter to fill up the bladder, which is right here. And we see something all around it. Can someone tell me what kind of injury it is?
Extravasation
Very good. And it's extravasating from where?
from the bladder.
Bladder, yeah. And I'm sure you've heard of bladder rupture before. There's two types. Do you know what those are? It's okay if you don't know.
I mean, there is intra and extraperitoneal.
Yeah.
Usually extra is not an operative, intra is
Yeah,
operative.
right on.
Intra.
So this one, which one do you think it is? Intra or extraperitoneal?
Obviously, it's intra because you have the contents inside the peritoneum.
Yeah, exactly. Good job. So you see the contrast also with urine is going around the small bowel loops. There. This is called the intraperitoneal bladder rupture. And I'll show another one. This is another patient. It's just a single image. You see the, it's also CT cystogram. There's contrast in the scrotum. It's tracking down the rectus sheath to join the left thigh. This is called extraperitoneal rupture. You can have both at the same time, but most commonly you have this extraperitoneal bladder rupture. And the other one that I showed you, this one is more rare, but we do see them here. So I wanted to show you this. It can be from trauma. It can be from, radiation cystitis, where the wall becomes very fragile and there's leak of the urine. It can be from Foley catheter insertion. So there are different etiologies to it. Okay, I'm gonna move on to this case. So I forgot which one it was. Oh, okay, I see. So when you're doing your first scroll to get your first impression, so we are in the theme of free fluid. I'm hoping that you guys caught the free fluid here, mostly in the retroperitoneal spaces, all the way around the psoas to the pelvis. Did anyone catch where this blood might be coming from? This is a trauma case. I'm sure it's a bit lagging on your computers, but I'll go back down to show you. If anyone knows the answer, just shout it out. Again, we see a lot of blood. If I stop here, do you see it?
So the pelvic,
Sorry, Marion, did you say?
pelvic fracture.
Yeah, you got it. There is a pelvic fracture. That's why you have to look for bones too. I'll show you. It's the same patient, but on the coronal view of the CT. And you can appreciate the right iliac wing fracture, which is comminuted, and it's causing a lot of retroperitoneal hemorrhage. Good job. Okay, so just a static image. So I already have the arrow sign. I'll guide you through this. So this is the aorta, abdominal aorta, and you can see that it has a big aneurysmal site. It was measured to be at least 8 centimeters. There's contrast in the non-excluded part of the lumen. This is all thrombosed. If I only had the aneurysmal sac of this size going around like this, I wouldn't be that concerned. So you see how the border is going around the psoas muscle and the vertebra? Does anyone know the name of the sign? It's in the spectrum of the acute aortic syndrome. So the name of it is draping sign. So this is already a confined rupture of the aneurysmal sac, but it hasn't totally ruptured. So this is contained and it's draping over the left psoas and the vertebral body. So this is called a draping sign. It means that the patient can rupture in any minute. So this is a very emergent case. If you miss this, then you will end up with this. A lot of retroperitoneal hematoma, and there's contrast extravasation. So this was the normal lumen, and now it's being excreted into the excluded thrombosed sac. So there's a high mortality to this. So that was the end of my free fluid section. I'm gonna speed up on the inflammatory changes, okay? Can someone confirm like how much time I have left? Like 3 minutes? Okay, I'll just go through. So
You've got about 25 minutes left.
oh really? Okay, I thought I was only given 40 minutes.
We've got a break afterwards, and we're happy for you.
Okay. Okay, I hope it's interesting so far.
Yes, it's great. So keep going.
Thanks. Okay, itis. So we talk about fast trending a lot. When I was in R1, I didn't know what it really meant. Now that I'm beginning in radiology, I asked my seniors, and fast trending just means hyperdense, ill-defined region in normal fat plane. So when you open a CT, then you have a lot of black area, which is normal fat, whether it be within the abdomen or subcutaneous fat. But if you see something like this, something very hazy, whitish, then that's called fat stranding. And it's very non-specific, doesn't mean a lot, but if you do catch it when you're scrolling, then you have to look to the adjacent organs to see if there's any inflammatory changes. So let's get into it. So single image of CT abdomen. Patient presents with right upper quadrant pain. Do you see anything?
There's some small bowel fat stranding near the liver.
Here?
Yeah.
Yeah, good job. And yeah, so very good. You caught the fat stranding. So yeah, it could be duodenitis, but is there anything that catches your eyes to help you?
Is there a gallstone?
Yeah, that's a gallstone. That's another gallstone. Those are radiodense, so we're lucky. Sometimes they're not that radiodense, so that's why after CT, sometimes you ask for ultrasound to check if there's gallstone. But yeah, indeed, this is a gallbladder, which looks a bit distended. The wall is enhancing. See, the wall is a bit bright. There's stones, one in the body and one near the neck of the gallbladder. And there's a lot of fat stranding, even here at the fundus. And this is causing some reactive inflammatory changes to the adjacent bowel, like you said. So this is an acute, uncomplicated cholecystitis. Good job. So another single image. A young patient presents with right lower quadrant pain. Does anyone see anything?
You have an appendiculus, and you have thickening in the wall of the appendix and some fast stranding around it. So that's acute appendicitis.
Yeah, so you're right on. This is fast stranding here all around. Appendix dilated more than 6 millimeters, which is our cutoff value. It's fluid filled with an appendicolith near the proximal segment. So in keeping with acute uncomplicated appendicitis, if you had more fast stranding than this, like if you had more fluid around or more dirty fast stranding around wall is discontinued, then that's when you call that it can be like perforated. But here this is, though I can still like trace the wall with my pencil, so I'll call this uncomplicated. And I was told by my seniors that if anyone can see the appendix, then it's likely abnormal, like inflamed. But if an R2 cannot find the appendix, then it means it's normal. Just the way we describe things. Another one. So this patient got bilateral pleural effusions, but ignore that. This is non-infused study, so no IV contrast given. That's why everything was with like gray, the same density. So your goal is to look for any fat stranding. I admit that this guy already has a lot of free fluids. Like this is, okay, not that. This, that's all free fluid. It becomes easier when you scroll to identify this free fluid. And you have to know where the source is. This is not a trauma case. Acute abdominal pain is the history provided. This, I didn't find, I didn't get the most obvious case for this, but I'll stop here. Okay. So this is the pancreas. If you, this is like a normal intraperitoneal fascia, but if you find this more evident than usual, it means there is fluid tracking along it. And there's a lot of fast stranding all around. You shouldn't have this dirtiness. It should be as clear as this fat here. So this is compatible with acute interstitial edematous pancreatitis. And I don't know which score you guys prefer, like modified Atlanta score versus the Balthazar score. But surgeons like Balthazar score. So this with fast trending and some free fluid around, I'll say at least grade C pancreatitis for this guy. Keep in mind that grade A pancreatitis, even if there's like lipase that's skyrocketing, we may not see any inflammatory changes on CT. So that's when we say that annoying sentence, correlate clinically. But here you have to check for fast trending, any involvement of the vessels, and then you repeat the CT scan in 48 hours with pancreas protocol to assess for any walled off necrosis or vessel involvement, pseudoaneurysm. But first, we don't really need CT pancreas protocol for pancreatitis. Okay. 16. I forgot what this one was. Oh, yes. Okay. So you can see that it's very ugly looking scan, right? What I mean by that is that, first of all, look at outside skin. You see this is very bright, dirty. That's from the edema, and that's what we call the generalized anasarca. On top of that, inside the abdomen, there is a lot of free fluid. I'm sure your eyes are getting used to checking for free fluid here. It's everywhere. Now, we need to find out where this is coming from. So it's got here, there's an NG tube, but it's in the normal position. Or maybe it's a dot pop, it's going further down. And then the patient has colicky abdominal pain, diarrhea. It's not COVID. Does anyone see what could be the cause of the patient's pain?
He has some dilated small bowel loops and prominent.
Mm-hmm.
I'm not sure if I see transition point.
I'll stop here. Do you see anything?
Here's a thickened transverse colon.
Mm-hmm. You get it. So
So colitis.
yeah, it is a type of colitis. So you see the ascending colon is affected, more prominent in the transverse, and it's extending all the way to the descending colon here. And the small bowel, yeah, they're dilated, but I'm thinking, yeah, there's no transition point, so likely reactive. And they're not super dilated either. The main abnormality is here in the colon. So the wall is thickened, the mucosa is enhancing, there's a lot of fast stranding, and there's the name of the sign. You see the white line goes around like that. That's called the accordion sign, and is pathognomonic for one type of colitis. Does anyone know what that is? Diarrhea isolation. Yes, C. diff colitis. You got it. So this is the pseudomembranous colitis finding. So it generally affects the entire colon. It's thickened. It's different than Crohn's disease, where it affects the terminal ileum mostly. It's different than the what was the other type? Not the Crohn's.
Ulcerative colitis.
Yes, thank you. The UC ulcerative colitis. Thanks, guys. That usually affects it doesn't give this enhancing mucosal wall finding. It's just more thickened, dilated, like sausage type colon. It's like if you remember this pattern, then you'll be able to catch C. diff colitis anytime on CT scan. And it's not ischemic either, because ischemic is usually a watershed area, like at the hepatic flexure, where the ascending and transverse colon meet, or the descending colon and the transverse colon meet, the splenic flexure. And here it's involving diffusely. And small bowel dilation, mildly dilated small bowel without transition points, likely reactive to what's going on distally. Okay, good job, guys. Okay, 17. Again, I'm scrolling down. There's an NG. Okay, I'm gonna go back up. Oh yeah, it's a revision case. So do you see fast stranding?
Just another pancreatitis.
Yeah, another pancreatitis. Here, was this the one with CB dilation? No, okay. So I just want to show you more marked pancreatitis here. Again, here what we'll be looking for is not only the inflamed pancreas, which you can appreciate better than the earlier case. There's a lot of stranding and free fluid, but you also have to look for abscesses. So abscesses look like very well-defined collection with Wim enhancement, enhancing like this kidney, but there's nothing around. So this is just another interstitial edematous pancreatitis. Chronic pancreatitis, you will see more, you wouldn't see this much of fast stranding. You'll see more atrophied pancreas with focal calcifications. Okay. Okay, so we went through free fluid, free air, itis. Now let's go into the last chapter, which is the lines. So this one was a trauma case where we did pan scan. The reason I'm showing the scan is, I told you earlier, it's very good to check for lines. I don't see any Foley catheter. These lines are all the ECG electrodes outside the patient. So it's very busy looking. Try to ignore those. Patient is intubated, so you can see, how do I remove that? What's the preferred time for CT alternative? Oh yeah, pancreatitis. So you can ask for rule out pancreatitis the moment the patient presents. That's the usual practice here at the MUHC and at the Jewish General. But what the guideline says is that you treat clinically, you don't need imaging. The only time you need CT imaging is to look for complications of pancreatitis. So 48 hours later, that's when you see necrosis, pseudocyst, or vascular complications like pseudoaneurysm or thrombosis. So by the book, you don't need CT to diagnose pancreatitis, except when you're also trying to look for other etiologies, or if you think this is the patient presenting late, you know, like homeless guy who drinks a lot and then had this pain for many weeks. And that's when you could ask for pancreas protocol. But the common practice here is you just ask for CT abdomen right away, and we'll just do classic CT and look for signs of pancreatitis. Even though we say there's no signs of radiological signs of pancreatitis, and you say there's a lot of elevated lipase, patient has those clinical picture that goes with it, then you just treat. Test you need is ultrasound. Yeah, so ultrasound you also ask because you want to see the etiology of the pancreatitis. So you guys, I'm sure you guys all already know better than I do. Most common types are the alcoholic or alcoholic pancreatitis, or the gallstone pancreatitis. So to rule out gallstone pancreatitis, CT is not the best modality because we don't catch all the stones. So we do ultrasound to look for the distal CBD to see if there's any stones, like most of us said here. Hope that answered the question. Yeah, that's the comment I get. So that's why we scan patients, but we often do repeat follow-up CT pancreas protocol a few days later to check if there's any complications. Thank you, Dr. Bake. So here, to come back to this case, I wanted to show you this. ET tube is in the right position above the carina. Normally, when the patient is intubated, to prevent aspiration, you guys put an NG, right? And can you see an NG tube going to the expected location of the stomach here? You might be wondering why I'm struggling with the scout, but scout is the best to check for any malpositioned tubes. So here I don't see anything. Yes, you got it. So there's a lucent line that's going into the lung in the right side. And we can confirm that on this. So you can see there are two tubes traveling down the trachea. So there's one larger one, which is the ET tube, and there's the second one, which shouldn't be there. And you see where it's going, follow, follow, follow. So the ET tube terminates at above the carina, and follow this one. Going all the way to the right main bronchus to the posterior segment of the right lung. The tip is right here. So that's one way to confirm the positioning of the NG in trauma cases. I thought it was cool. Here, yeah. Oh, check the chat. NG is always patient right lung. That's good to know. Okay, it's another case. There is a mispositioned iatrogenic thing. Can anyone tell me?
Is the balloon inflated inside the urethra?
Yeah, so the Foley catheter was inserted, but like Mustafa said, the balloon is inflated in the urethra. So good job. This balloon should be in the bladder, not here. Now this one. So this patient, I'll give you the history. Had double J stents by urology a few days ago comes back for left flank pain. What do you see?
I think the left double J migrated to inside the bladder.
You got it. So what it should normally look like is like in the right side. So you have the tip of the double J in the right calyx going down the ureter, and it should join the bladder and have another loop going like this. See this is the tube, and it should go down like this. And you see another thing that's coiled up in the bladder. And if you go check the left kidney, you don't see the double J. This is just a calcification or stone. So good job. That's a double J that's migrated here. Okay, this is a last bonus case. Presents with abdominal pain. I don't have any other images. Is this, firstly, is this normal or abnormal? If it's abnormal, what you can be?
Is this a mule case? Somebody who's
Sure.
who will pause cocaine or something like that?
You got it. Good job. Let's see what other people said. Yeah, the body packer. So you have multiple packed drug in the colon. It's not causing, so things you have to look for is, yes, it is a lot. So yes, you're very good at finding these, good job. And then other things you have to look for, things we mentioned so far, free fluid, free air. Is there perforation? Is there free fluid? You have to look for those. This guy, I'm sure you presented earlier, there's nothing perfed. This is what they extracted in surgery. So I thought it was a cool case. So to recap, when you are still waiting for our prelim report, but there's nothing, we are being super slow, go ahead, open up the scan, go through the checklist. You don't have to go through it organ by organs, but look for free air, free fluid, inflammatory changes, look for the fast trending, check the positioning of the lines. And if you're still stuck, what we like to do is go back to the older ones. It really helps us a lot. Like once I had like a huge renal mass / abscess, I didn't know what it was. The patient had 3 years ago, so it really saved my life. And then correlate clinically. You guys have the advantage of seeing the patient yourself, feeling the belly yourself. So go for it. So I'll be happy to answer your questions. If you can email me at this address. Anyone who has questions left, I can go back to the cases.
That was really, really useful. Thank you, Taehoo. We're generally very good at ordering CT scans in eMERGE, but not so good at actually reading them. Just give people a couple of minutes if they have any questions.
Thank you guys. You guys were super interactive, the best audience I've ever had.